Okay, so I'm going to give a quick overview of the Ehlers-Danlos syndromes and hypermobility spectrum disorders. The Ehlers-Danlos syndromes are a spectrum of monogenic disorders with a very wide range of phenotypic severity and predominantly affecting the joints, skin, and the blood vessels and internal organs to varying degrees. So most forms of the Ehlers-Danlos syndromes are caused by defects in one of the fibrillar collagens or of the enzymes involved in fibrillin collagen processing. But there are a number of other rarer types of Ehlers-Danlos syndrome that have been recently found to be caused by defects in the biosynthesis of other molecules in the extracellular matrix and molecules involved in intracellular trafficking, secretion, and assembly of the extracellular matrix molecules. So just a brief review on the fibrillar collagens. These are the major structural components of the extracellular matrix, and they include collagens types 1, 2, 3, 5, 9, and 11. And the fibrillar collagens are trimeric molecules that may be made up of 3 identical or genetically distinct chains, which we call the alpha chains. And this is an older cartoon, but it really does a good job illustrating how the 3 alpha chains are synthesized and they assemble into a trimeric triple helical molecule. The amino and carboxy terminal ends are cleaved, and then the fibrils line up into the mature collagen molecule, the fibrils. So in 2017, there was a new classification of the Ehlers-Danlos types, and there were 13 different types that were defined at that time. The classical type, the vascular type, and the hypermobile type are the most common of these 13, and the others are really quite rare. With some of them, only a handful of different cases have been reported. I'm going to talk about the diagnostic criteria for the most common types, the classical, vascular, and hypermobile, and just give a brief overview of some of the other rarer types. So the major criteria for the classical type include skin hyperextensibility and atrophic scarring, and then joint hypermobility. Those 2 are the major criteria. And the skin is considered to be hyperextensible if it can be stretched over a standard cutoff in 3 of the following areas. So the cutoff that we use is 1.5 centimeters for the distal part of the forearms and the dorsum of the hands, and then 3 centimeters at the neck, elbows, and knees. So the skin hyperextensibility in the classical type is really the most dramatic skin hyperextensibility of any that we see in the different Ehlers-Danlos syndromes. And this illustrates that skin hyperextensibility. The abnormal scarring can range in severity. Many patients have extensive atrophic scarring at a number of different sites. They can sometimes be hemosiderotic. And a minority of the patients with the classical type of EDS have more mild scarring. But typically, when I'm wondering if a person has the classical type, I just go directly to the shins and look at their shins, because this type of scarring that you see in the photograph that's labeled A here is very, very typical of the classical type of EDS. And you start to see scarring even in youngsters. What happens is the skin is just extremely fragile, and it can Like what happens is when they're starting to walk, they bump into coffee tables and the skin will split. And then you see these kind of fish mouth-like scars that develop on the shins. And on the extreme right-hand side of the slide here is kind of a typical atrophic scar where the edges of the scar have separated out and created an atrophic looking scar. We use the Beighton score to define generalized joint hypermobility, and I'm sure all of you are familiar with this scoring system. It's a 9-point scale that looks at the elbows and knees and the ability of the person to touch their thumb to the forearm and to bend the fifth finger back more than 90 degrees at the metacarpal phalangeal joint. And then the 9th point is if they're able to put their palms on the floor with their knees straight. So you get 1 point for each side for the knees being more than 10 degrees in hyperextension, elbows being more than 10 degrees in hyperextension, and the fifth finger metacarpal phalangeal more than 90 degrees, and the thumb to the forearm. So another thing that happened with the 2017 criteria is we changed the cutoffs for generalized joint hypermobility depending on age. So we now consider that prepubertal children and adolescents have generalized joint hypermobility if the Beighton score is more than or equal to 6. For men and women up to age 50, we use a cutoff of 5. And for men and women older than 50, we use a cutoff of 4. For the classical type of Ehlers-Danlos syndrome, we can make a clinical diagnosis if they have the major criterion 1, which is the skin hyperextensibility and atrophic scarring. And then in addition, either the major criteria 2 of joint hypermobility, generalized joint hypermobility based on the Beighton, or 3 of the 8 minor criteria which are listed here, including easy bruising, soft, doughy skin, skin fragility or traumatic splitting. Molluscoid pseudotumors, these are the lesions that you saw in the knees of that gentleman in the earlier slide were molluscoid pseudotumors on his knees. Subcutaneous spheroids are kind of under the skin. They almost feel like a little piece of gravel underneath the skin. Hernia or a history of hernia, epicanthal folds, complications of joint hypermobility, or a family history of a first-degree relative who meets the clinical criteria. So for classical EDS, confirmatory analysis is recommended for any patient meeting the clinical criteria. And we look at the genes COL5A1 and COL5A2. And molecular analysis of those 2 genes should find a causal mutation in more than 90% of patients with classical EDS. And we use that as the standard confirmatory test. And this was the reference from Dr. Ann DePapp's lab that showed that 90% of patients with these redefined criteria should have variants in type 5 collagen. Now, the vascular type of EDS, the major criteria include a family history of vascular EDS with documented variant in COL3A1, arterial rupture at a young age, and typically these are the medium-sized arteries in the abdomen, like the splenic artery, hepatic artery, gastric artery, those size arteries. Spontaneous sigmoid colon perforation in the absence of known diverticular disease or other bowel pathology. Uterine rupture during the 3rd trimester in the absence of a previous C-section. with or without severe peripartum perineum tears. And then finally, a carotid cavernous sinus fistula formation in the absence of trauma. The minor criteria include bruising, thin translucent skin with increased venous visibility. There's a characteristic facial appearance, and I'll show you a picture of a woman with that characteristic facial appearance in a minute. Spontaneous pneumothorax, an older looking appearance, especially of the hands. Club foot, congenital hip dislocation, hypermobility of the small joints in the hands. And often people with the vascular type of Ehlers-Danlos syndrome will not have generalized joint hypermobility, but will only have obvious hypermobility in these small joints in the hands and sometimes the feet. Tendon and muscle rupture, keratoconus, gingival recession and gingival fragility, and the early onset of varicose veins. These are all the minor criteria for the vascular type of EDS. And this is the kind of typical, what we consider to be the typical facial appearance with a sort of a triangular face, very prominent eyes, diminished subcutaneous fat, and a thin nose and thin lips. When you see this facial appearance, it's very suggestive of the vascular type of EDS, but not every person with the vascular type of EDS will have this facial appearance. So it's not seen in every case. And you can see the older looking hands in this, this woman who's just in her 30s, and the biochemical analysis that shows a diminished presence of the amount of collagen type 3. So the committee that defined the new criteria for vascular EDS, really, they decided against making hard and fast diagnostic criteria, and instead offered us minimal criteria suggestive for vascular EDS. And so they said, if you see any of these things, you should really be thinking about the vascular type of EDS. And if you're thinking about the vascular type of EDS, you should be ordering testing to rule it in or out. So those minimal criteria are the family history of the disorder, arterial rupture or dissection in a person less than 40 years of age, an unexplained sigmoid colon rupture, spontaneous pneumothorax, and in the presence of other features consistent with vascular EDS, any of these criteria should lead to diagnostic studies to determine if the person has vascular EDS or not. And testing for vascular EDS should be considered in the presence of a combination of the other minor clinical features listed here. So the diagnosis of vascular EDS rests on the identification of a causative variant in one allele for COL3A1, which is a gene encoding type 3 collagen. The sequence analysis for COL3A1 will identify a pathogenic variant in 95% of cases, and deletion duplication analysis will give us another 2% or so. There has been really good work from Dr. Peter Byers' laboratory demonstrating that there's a very interesting phenotype-genotype correlation where survival is affected by the mutation type and the molecular mechanism in vascular EDS. So variants that cause loss of an allele will have a more mild phenotype than variants that are missense variants and cause changes in the sequence of the particularly for substitutions in the triple helical region of the collagen. Okay, moving on to the hypermobile type of Ehlers-Danlos syndrome. The criteria that were offered in 2017 were designed to emphasize the syndromic nature of the condition, to reduce clinical heterogeneity, and to facilitate research into the underlying causes of hypermobile EDS. Because hypermobile EDS is the most common of the types of Ehlers-Danlos syndrome, and the only one for which we do not have a molecular explanation. And we certainly expect that further clinical experience and research will lead to revision of these criteria with time. So just to go back to the 1997 criteria for what we were calling the hypermobility type of EDS at that time. This was a publication, Peter Byton was the first author in 1998. And the major criteria then were skin involvement with hyperextensibility and or smooth velvety skin and generalized joint hypermobility. And the minor criteria were recurring joint dislocations, chronic joint and limb pain, and a positive family history. And the only guidance that that 1998 publication gave us in terms of establishing a diagnosis was that the presence of one or both of the major criteria was necessary for a clinical diagnosis. So this was not a very specific set of diagnostic criteria. A person with generalized joint hypermobility alone could be diagnosed with the hypermobility type of EDS under these criteria. And actually, a person just with smooth velvety skin could be diagnosed with the hypermobility type. So it was too wide a net. And so the effort in 2017 was to narrow the diagnostic criteria and generate a more homogeneous group of people in that bucket of people. And it was renamed Hypermobile EDS and now requires 3 different criteria for establishing the diagnosis. So those 3 criteria are, well, the first criteria is generalized joint hypermobility, again with the Byton score, same cutoffs we discussed for the classical type of EDS. The committee also said there's a questionnaire called the 5-point questionnaire, which was designed by rheumatologists to establish whether or not a person has generalized joint hypermobility. And so if a person is 1 point below the cutoff for the Byton score and they have 2 positive items on this 5-point questionnaire, we can kind of push them over the finish line and say, okay, we'll call this generalized joint hypermobility in this person. And this is the 5-point questionnaire. It's, can you now or could you ever place your hands flat on the floor without bending your knees? Can you now or could you ever bend your thumb to touch your forearm? As a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? As a child or teenager, did your shoulder or kneecap dislocate on more than 1 occasion? And finally, just simply, do you consider yourself to be double jointed? So some of these questions are redundant to the Byton, and I think this is one area where, as the criteria are considered, inclusion of this 5-point questionnaire, I think it may eventually be excluded from the consideration, but that's still to be seen. So criterion 2 has 3 features in it, and we need 2 of the 3 features to say that criterion 2 is met. So The three features are systemic manifestations of a more generalized connective tissue disorder, a positive family history, and musculoskeletal complications of the condition. The systemic features, we need at least 5 of a list of 12. Those things include unusually soft or velvety skin, mild skin hyperextensibility, not as extensive as what we see in the classical type, unexplained stretch marks without a history of significant weight change, bilateral piezogenic papules on the heels. These are little bumps that appear on the heels when you put all your weight on your heels. Recurrent or multiple abdominal hernias, atrophic scarring in at least 2 sites. Pelvic floor, rectal, and or uterine prolapse without a history of morbid obesity or other known predisposing conditions. Dental crowding and a high or narrow palate. Arachnodactyly, defined by the positive wrist and thumb signs. Those are, we put the thumb across the palms and close our fingers over it. If the thumb sticks out the full distal phalanx, that's a positive thumb sign. And the wrist sign is positive if the little finger and the thumb overlap by the full distance of the nail on the little finger. An arm span to height ratio more than 1.05, mitral valve prolapse, or an aortic root dilatation with a Z-score of +2. I have a feeling also, just watch this space. I'm not sure exactly how it's going to pan out, but I think the echocardiographic criteria are probably going to come out of these criteria eventually. Also, especially because if we see aortic root dilatation, we really should be going down a different diagnostic pathway. We do see mild aortic root dilatation in some patients with hypermobile Ehlers-Danlos syndrome, but it is usually not progressive, almost always not progressive. In fact, if it is progressive, it makes me think it's got to be some other hereditary disorder of connective tissue, and specifically not the hypermobile type of EDS. So we call a positive family history if one or more first-degree relatives independently meet the diagnostic criteria for hypermobile EDS. And the musculoskeletal complications, we fulfill feature C if at least one of the following are present. Musculoskeletal pain in 2 or more limbs daily for at least 3 months, chronic widespread pain for more than or equal to 3 months, and recurrent joint dislocations or frank joint instability in the absence of trauma. So one of those being present fulfills feature C. And then criterion 3 basically says that we have done our due diligence and we have excluded all other items in our differential diagnosis. We've really thought carefully. We've asked about other heritable and acquired connective tissue disorders, and the exclusion of alternative diagnoses that may also include joint hypermobility because they cause either hypotonia or connective tissue laxity. Now, some of our patients with hypermobile Ehlers-Danlos syndrome may have autoimmune rheumatologic conditions. They may have lupus, they may have rheumatoid arthritis. The criteria suggest that if that is the case, that we not use the presence of pain as one of the features in criterion 2, but if they have either a first-degree relative, so they have A and B, or if they have instability, you can still get them across the finish line and say that they meet criteria. Now, when we think about syndromes, the Hannigan et al. Defined it as a pattern of anomalies, at least one of which is morphologic, that are thought to be causally related. And when the committee that was looking at the hypermobile type of EDS back in 2016 and 2017 thought about this, they recognized that the presence of joint hypermobility in combination with secondary musculoskeletal anomalies, that does not suffice for delineation of a genetic syndrome, and that the joint hypermobility may occur independently or in the context of multiple genetic disorders. So in terms of thinking about classifying patients with joint hypermobility, they came up with this idea that really hypermobility, there's a spectrum of hypermobility, which includes people who have asymptomatic joint hypermobility, and that asymptomatic joint hypermobility may be localized in only one or a couple of joints. It may be generalized, meeting the criteria for the Beighton scale, or it may be peripheral, as we see in the vascular type of Ehlers-Danlos syndrome, where it's just the small joints of the hands and feet that are hypermobile. So we may have people with asymptomatic joint hypermobility. We may have people who have a well-defined syndrome that includes joint hypermobility. And then we may have some people with symptomatic joint hypermobility, but who do not meet the diagnostic criteria for a syndrome. And those people we consider to have the hypermobility spectrum disorders. So the spectrum of joint hypermobility then includes asymptomatic hypermobility, which may be generalized, peripheral, or localized. Generalized hypermobility spectrum disorder, peripheral hypermobility spectrum disorder, localized hypermobility spectrum disorder, or historical hypermobility spectrum disorder, which includes the presence of the historical presence of joint hypermobility, but which we do not now see on exam. And then at the extreme end of this spectrum of joint hypermobility, we have the hypermobile type of Ehlers-Danlos syndrome, in which the Beighton score is positive and musculoskeletal involvement is possible and usual, I would say. All right, now I'm going to move on to talk about a few of the rarer types of Ehlers-Danlos syndromes. Tenascin X deficiency is an autosomal recessive form of EDS characterized by marked skin hyperextensibility, easy bruising, joint laxity, without atrophic scarring or poor wound healing. And people with this tenascin X deficiency also may have severe diverticular intestinal disease. They may have mitral valve prolapse that's severe enough to require valve replacement. And they also may have obstructive airway disease. You also have very typical kind of wrinkling of the palms of the hands and also on the feet. There is an autosomal dominant form of tenascin X deficiency. There's a paper from 2003 in which Zweers and colleagues looked at 20 obligate heterozygotes with tenascin X mutations. And they saw generalized joint hypermobility in 45% of these obligate heterozygotes. All of these were women. None of them had skin hyperextensibility or easy bruising. And then in another study, in 80 patients with hypermobile Ehlers-Danlos syndrome, 6 had low levels of tenascin X in the serum, and 2 of those had heterozygous tenascin X variants. So I think this is an area, tenascin X is a very difficult gene to analyze in the laboratory because there are pseudogenes for tenascin X, and it's in a region that's hard to sequence. So we may yet find that there are more patients with heterozygous tenacin X variants in that hypermobile EDS population. The kyphoscoliotic type of Ehlers-Danlos syndrome presents with neonatal kyphoscoliosis, generalized joint laxity, which can be really quite extreme, skin fragility, severe muscle hypotonia at birth. And biochemical analysis identifies a deficiency of lysyl hydroxylase, and the variants are in PLOD1, the gene that encodes the enzyme, which hydroxylates lysine on the collagen molecules, and this causes the kyphoscoliotic form of EDS. The arthrochalasia type of EDS presents with bilateral hip dislocations and really doughy, kind of redundant skin. Some of the patients have contractures of the fingers and toes, umbilical hernia, kyphosis of the thoracolumbar spine, and muscle hypotonia. And this type of EDS is caused by variants in either the alpha-1 or the alpha-2 chain of type 1 collagen. And these variants are in a very specific location that interferes with the cleavage of the N-propeptide. So this is an autosomal dominant condition, the arthrochalasia type. It can be caused by either COL1A1 or COL1A2 variants. The dermatosparaxis type has epicanthal folds, downsloping palpebral fissures, blue sclerae, micrognathia, very prominent lips, and facial scarring, easy bruising. And this is an interesting kind of counterpoint to the previous one, because it's an autosomal recessive condition, but the molecular consequence of this is the same as if you have a COL1A1 or COL1A2 variant that prevents the cleavage. In this case, it's the enzyme that's deficient. In the arthrochalasia type, it's the substrate. So in this case, the mutations are in ADAMTS2, and that's the enzyme, the gene that encodes the procollagen N-proteinase enzyme, which cleaves that N-propeptide of types 1 and 2. So this is an autosomal recessive condition. The musculocontractural type is manifest by malar hypoplasia and downsloping palpebral fissures, blue sclerae, microcornea, a long philtrum, thin upper lip, macrognathia, so prominent chin, which is often pointed in appearance. And this condition is caused by mutations in CHST14, which encodes an enzyme called dermato-4-sulfotransferase, which is key in the synthesis of dermatin sulfate. And so if you're not sulfating if you're not creating dermatin sulfate, it disrupts the ratio of dermatin sulfate to chondroitin sulfate, which is an important regulator for multiple glycoprotein components of the connective tissue. The cardiac valvular type is characterized by cardiac valvular insufficiency. The mitral and aortic valves can be affected and require surgical correction. Patients have joint hypermobility and hyperextensible skin, and this condition is caused by a lack of alpha-2 type 1 chains in type 1 collagen. So type 1 collagen is a heterotrimer with 2 alpha-1 chains and 1 alpha-2 chain, but if you don't have COL1A2, you get a homotrimer of alpha-1 chains, and that results in this cardiac valvular type of Ehlers-Danlos syndrome. Now, just for a few minutes, I'd like to talk about the fact that Ehlers-Danlos syndromes in general are complex and multidisciplinary disorders. And we know for most of the patients we see are hypermobile Ehlers-Danlos syndrome. Many of the patients who are diagnosed with hypermobility spectrum disorders also present with complex multidisciplinary issues. So Heidi Collins coined this phrase: if you can't connect the issues, think connective tissues. We see musculoskeletal involvement with joint laxity, instability, subluxations, dislocations, a tendency for tendon ruptures and tears, chronic musculoskeletal pain, and frequent sprains. Cardiovascular manifestations, this audience needs no introduction to the orthostatic intolerance, but we also see mitral valve prolapse and the aortic root dilatation I mentioned earlier. Neurologic involvement can include headaches, the cervicomedullary syndrome, and I'll say a little bit more about that in a minute, neuropathic pain, occult tethered cord, cerebral venous insufficiency, degenerative disc disease, spinal instability, and small fiber neuropathy. The cervicomedullary syndrome was defined by a consensus statement of the Chiari and Syringomyelia Foundation Multidisciplinary Colloquium in 2013 to include headache and suboccipital or neck pain and bulbar symptoms of altered vision, double vision, nystagmus, diminished hearing, dizziness, imbalance, vertigo, choking, difficulty swallowing or speaking, dysautonomia, disordered sleep architecture and sleep apnea, and symptoms of myelopathy. So when we see a constellation of symptoms such as this, it suggests the cervicomedullary syndrome, which can be due to either Chiari malformation or instability at the craniocervical junction or at C1-2. GI manifestations are very common in this population. And again, I'm talking about both the hypermobile type of Ehlers-Danlos syndrome, hypermobility spectrum disorders, and also we see these complications in the classical type of Ehlers-Danlos syndrome as well, with irritable bowel syndrome, bloating, abdominal pain, esophageal reflux, food intolerance, diarrhea, constipation, fecal incontinence, hernias, and sphincter of Oddi dysfunction. Recognizing that there's a significant overlap with autonomic dysfunction with the GI manifestations and also potentially with mast cell activation. Urologic features, and again, patients may be diagnosed with interstitial cystitis, and that can be secondary to mast cells. So important to think about that mast cell involvement with multiple different organ system involvement, but urinary urgency, frequency, burning on urination, difficulty initiating the urinary stream or emptying the bladder completely, and urinary incontinence and frequent urinary tract infections. So some of these can be due to occult tethered cord, and some can be due to mast cell, and some can be due to anatomic variants in the urinary tract itself. In the hematology allergy department, we think about a history of hives, rashes, flushing, itching, frequent infections, severe allergies, autoimmune disorders, and a history of blood clots. And certainly these first 4 items would make us wonder about the presence of mast cell activation. Some things I think about in terms of treatment strategies for the musculoskeletal issues, to stabilize unstable joints on an as-needed basis. People sometimes worry that braces will cause weakness, but if patients continue to use their muscles, they should be protected against that. Physical therapy is really a mainstay for treatment. It should include manual therapy to get the muscles to relax before patients do the toning and strengthening necessary to stabilize their joints. And that would include DP, ultrasound massage, use of electrical stimulation, and far infrared laser therapy, among other things. And dry needling can be very helpful. If the TENS machine is helpful in the PT office, we consider using one at home. They're now very affordable and easily obtained for home use. Epsom salt baths or foot baths can help with muscle relaxation. And then PT for toning and strengthening the muscles, particularly considering aquatic PT, is really, really helpful to many of these patients. I prescribe a compounded analgesic cream that has a combination of diclofenac, cyclobenzaprine, baclofen, gabapentin, lidocaine, and magnesium. Some of my patients call this zebra sauce, and they really like it, but the problem is that it can be very difficult to get insurance to cover a compounded product. There's another product that's marketed through Amazon, manufactured by a company called Golden Sunshine. It's called Pain Terminator, which is a combination of different Chinese herbs. And that one is more affordable and can be very helpful too. We use muscle relaxants if necessary, and I always say beware Botox, especially in the muscles in the neck, because if the muscles of the neck are paralyzed, then the person can lose their ability to hold their head up for 3 or 4 months, which is not a desired outcome. So coping strategies include cognitive behavioral therapy, mindfulness-based stress reduction, biofeedback and neurofeedback, patient support groups, and exercise can be extremely helpful. The international classification is available at the Ehlers-Danlos Society website, and all of these diagnostic criteria are available there. There was a special issue of the American Journal of Medical Genetics that was published in March of 2017, and all of the papers from that issue are available freely at the Ehlers-Danlos Society website. So that is the end, and thank you very much for your attention, and thanks so much to the Society and my patients and their families for letting me be part of their journey.